Oh,
Welcome. We are so glad that you accommodated us, really. Yeah.
Oh, yes. Well, thank you for having me. I just wanted to start by, I know we haven't started any formal recognitions yet, but I did want to say my deepest condolences on the nurse who passed away at Kensington Village, Brambini. You know, he was really well respected and well loved by the community. And again, I'm just so very sorry. In addition, there's,
you know, and when people were asking me yesterday from the media with good intentions, if it was at work or not at work, it's irrelevant. It's irrelevant. It's irrelevant. You know what I mean? And today in London, you have another college, right? Another PSW. I mean, 7 PSWs, guys. We need to take account of what's happening there, right? Yeah, it's, yeah, we have a lot of work to do and we need to do it urgently.
Yeah. Agreed.
Yeah, yeah. And you have a president-elect there that will help you do that work. How about that?
That's right, Morgan.
Yes. Yeah, we're just, Allison, who's one of the nurse practitioners here, just sent me a message to ask if she was on the right call and if I could see her, which I can't see her. Oh, now I can.
Let's see. Oh, good.
Okay, well, I guess we'll get started then. So welcome everybody to our virtual Take Your MPP to Work visit with MPP Kernahan. Thank you so much for joining us. And also thank you for acknowledging the loss of the nurse in London, the nurse from the long-term care home, as well as the PSW from essentially a long-term care home in London, and the loss of lives that we've seen during COVID, particularly in long-term care and amongst healthcare workers, is devastating. So thank you for acknowledging that at the outset of this. And during Nursing Week, a time of celebration is also a bit of a time of mourning for us here. Thank you everybody for joining us. This is our first virtual Take Your MPP to Work visit at Parkwood, so through St. Joseph's Healthcare London, and I'm so glad that so many different people were able to join us. Today we're going to hear from a variety of different people who work either at Parkwood Institute, St. Joseph's Healthcare London, or specifically on 5B South. So 5B South is a unit that we have opened. It's a subacute medicine unit that we opened here at Parkwood as part of the pandemic planning. So it's a surge unit that's taken some patients from London Health Science Centre to help create capacity in acute care and keep their operating capacity low to make room for patients who may need acute care services during COVID. So we have 40 patients on our inpatient unit here. So one of the benefits of having this unit featured as our Take Your MPP to Work visit is that you'll get to hear about a lot of different units, because people will take some time to talk about their usual work, what they normally do during the course of their work, and then how that's changed a bit during COVID-19. So the staff members, the nurses, the allied health team, the PSWs, that are working on 5B South come from a whole bunch of different programs across not just Parkwood Institute, but the rest of St. Joseph's Healthcare as well. So we're really glad to be here together on 5B South and taking care of this patient group. So we'll hear a bit from a variety of different people. Terence, do you have anything that you want to say at the outset of the meeting?
Well, you know, David said, apart from condolences, I wish you all a very excellent Nurses Week. We could not be reliant on the amazing care that you offer. And also, as it turns out, my mother was just recently in Parkwood. She was recovering from a broken leg, was transferred from Victoria to Parkwood, and has nothing but the most amazing things to say about the care she received from all of the nurses there. It's absolutely phenomenal. So she's doing well.
Great. Thank you. Okay, so we'll turn it over to you, Roy. So Roy Butler is the Vice President that's responsible for Parkwood Institute and Mount Hope Center for Long-Term Care.
Thanks, Morgan. Can you hear me okay?
Yep.
Okay, great. So welcome, everyone. Welcome, Terence, and welcome to St. Joseph's Healthcare London. We're going to focus particularly on Parkwood, Maine today, which is one of our 5 main sites across St. Joseph's Healthcare London. And Terence, you've been here a couple times. We've met a couple of times, but just for people on the line, at Parkwood, Maine, we have a variety of services here. It's a place that over 100 veterans call home. And the average age of those veterans is 93. And then we also have over 200 additional beds in addition to the veterans for our rehabilitation programs, our specialized geriatric services programs, complex care, and palliative care, and also provide a variety of outpatient services here. During the pandemic, obviously, we've had a real focus on many things to keep both the patients we're serving, our community, and our staff safe. One is, the screening of anybody who is entering our building. Again, building on our baseline infection control practices, are heightening and enhancing the infection control practices, ensuring we've got the right PPE for those, for our staff and physicians. Limiting the presence of people in our building other than essential visitors, which has been, you're going to hear about how we've kind of creatively dealt with some of that on this particular unit. Maintaining social distancing and really, obviously, stopping all services other than those that are deemed to be the most critical right now. So one of the key pieces in our collaborative work across the city to create surge capacity in both acute care and an intensive care unit was looking to open additional beds here at Parkwood, Maine. And it's been really quite an amazing story. Like in the matter of a few weeks, we opened over 70 net new beds here at Parkwood, Maine. And 40 of those beds are on the unit that you're going to hear a little bit more about today. And these were, for the most part, patients who were at London Health Sciences Center who did not need acute care hospital services and were waiting for their next step, which was into long-term care. So we're talking about, a variety, but mainly older adults with frailty, multiple comorbidities. English might not be their first language, high prevalence of dementia, mobility issues. And, came from LHSC, and for many of them had been there for some time. So just even the movement to a new location where they didn't necessarily have their family members to support them while they're in, creates a fear and anxiety on top of everything else that's going on.
I wanted to say I experienced one of them through the generosity of Morgan that called me to translate.
Oh, okay. There you go. Thank you.
But actually, it was delightful. It was delightful.
And it was very helpful.
To hear the outcome of it was even more delightful. So here you go.
Oh, thank you. Well, that's a neat story. And Terrence, I'm glad to hear your family member also had a good experience here. So I'm so proud of the entire team here at Parkwood, and what they've done over the last weeks and months has been phenomenal. So in this 40-bed unit, really it got created by staff who were getting redeployed from different areas, who may not have really worked together as a team before, and they just all stepped up and had a holistic approach to care, whether it's their medical, physical, their mental health, their emotional, social, spiritual, and really just looked at mobilizing, restoring function in many of these patients, and in the whole spectrum, and also providing amazing compassionate care to a couple of those patients who have passed away since being with us. So I'll turn it over to the stars of the show, who are the rest of the people on the call. Just wanted to shout out a big thank you, and for all those nurses on the line, a happy Nursing Week. And 2 days after the 200th anniversary of Florence Nightingale, maybe. But congratulations to everyone, and for the physios and speech language pathologists on the call. It's Physio Month and Speech Language Pathology Month as well. So thank you. But really, the entire team has just been phenomenal. So I'll stop talking because I could go on and on about the team. But thank you all for being here today. And I think well, I'll let you, Morgan. You're the MC. I'll let you. I don't know who we're turning it over to next. I think Barb, maybe.
Yes, thanks, Roy. So we are turning it over to Barb. So Barb is an RN who works in the Access office here at Parkwood. So the Access Office, I'll let Barb talk to you about what she does here. So why don't you tell us a bit, Barb, about what your usual role is and any changes that have happened because of the COVID-19 pandemic?
Sure. So as a RN in the Access Office, we review all the referrals that come to Parkwood. Because it's a rehab hospital, patients have to apply to be accepted to the programs. So the referrals come through us. We use an SBAR tool, situation, background, assessment, and recommendations to collect our data. We look at their stay in acute care, their past history, their labs, what kind of tests they've had done, comorbidities that might influence decisions. And then we look at their function, how they were functioning previously in the community, and then how they're functioning now. And then we look at the goals, what types of things, what do they need to achieve to be able to be successful to go back to the community, hopefully back to the home that they were living in. Sometimes it's back to retirement homes, etc. So with COVID-19, we had an influx of these surge referrals that came into our office. And for a while, we were kind of stockpiling them, not really sure what the plan was going to be. And then all of a sudden on a Friday afternoon, we were told that we could go ahead and start to process these files. So we, got through a few and then realized suddenly that the admissions were going to be needed by Monday and we weren't going to get through them all. So that first weekend, I came in and worked for over 8 hours on Saturday. Filled out all the SBAR tools for the initial group of patients that had come. And then Allison will tell what her role is, but Allison worked closely with me that weekend as the nurse practitioner to review, just looking at medical stability and making sure that these really were the types of patients we wanted to put into these beds. So then when Allison had finished her role, the files came back to us in the Access Office. And then we worked closely initially with Allison and some unit leads, and then more so with Morgan once the 40-bed unit opened up, to decide how many patients we were bringing each day and how we were going to get these beds filled and fill them as quickly and as safely for the patients as we could. So there's a computer system where we move patients through books and do pre-reg and all that stuff, but that's kind of the more technical issues of it. But basically, that's us in a nutshell. We collect the data, we present it to the person that we're reviewing with, and then we get the patients into the right beds. Any questions?
I don't believe so. Thank you, Barb. That's a great deal of work to mobilize at this time, especially over the weekend, to try to get folks into Parkwood. So thank you.
Awesome. And it's the Access Office has a group of RNs that work in there that do a really great job of preparing all of the referrals and triaging them to the appropriate area, making sure that they get all the information so we can make a really informed decision about safely moving patients from acute care to a post-acute care setting.
At some point, Morgan, whenever you think is appropriate, because someone may address it, I actually would like also to hear the human side of how you prepare those persons to move from one setting to another, given that some had language barriers, given that they have other issues, the family is not there. So how that, not only that I understand perfectly and fantastically what you did with both the health issues side or illness issues or comorbidities, but the human side must have been very complicated too, because I mean, it's just moving a person, like in normal times, it's complicated, to move people from that have been waiting for ALC long and then move them to somewhere else. Here, imagine, without family, without nothing. It must have been pretty dramatic. And so that preparation, I would love to hear, given the stress of time for you to actually move them. How were you able to manage that that necessity, that need for clients, for residents, for people?
Yeah, and I would say, so that part was a joint effort between London Health Science Centre and our team here at St. Joseph's. So London Health Science Centre was to inform them that they were coming. And then we would also call the family once the patient arrived to let them know that they were here, to tell them the unit extension, if the patient was able to talk on the phone, to tell them the room extension. I'll leave the family connection piece to Kim, because she's done a really great job with their team on connecting with families. But it was a rocky transition. to get the patients over here because it happened so rapidly, and that settling in period for the patients was a bit difficult initially, just because there was so many new patients.
I can imagine. Yeah.
Okay.
Thank
So
you.
Allison is a nurse practitioner who works here at Parkwood Institute, normally in outpatient geriatrics, but has been really kind of helpful in getting the patients here and providing some ongoing care to inpatients during the pandemic. So Allison, do you want to tell us a bit about your normal role and then what you've been doing during COVID times?
Sure. So as Morgan said, typically I'm in the outpatient geriatrics team. So we do outpatient consultations and recommendations back to family doctors typically. And my first kind of experience with pandemic response was in a voluntary role with the COVID-19 sort of pandemic response team, which started as just a small team of NPs. And then, you know, we kind of thought it wouldn't ever kind of amount to this big of a response, but then it did. So my director approached me about kind of helping with the setup and referral review and inpatient management of patients, those subacute medical patients transferred from acute care. So in those early days, you know, the later weeks in March, spent a lot of time with Barb reviewing patients again for medical stability. And we organized the transfer to acute care, which, as Morgan was saying, it was a little bit rocky. You know, these patients, a lot of them have cognitive impairment, and you know, it was a bit of a rough transition, but we had such a great team up there of OTs, PTs, rec therapists, nurses. We had staff from the Neuro Rehab Center who were kind of trained in more behavioral management, who were amazing. And so we just had, I'm sorry if I'm forgetting people, but we just had a really excellent staff. And, you know, after a few weeks went by, we were kind of running a pretty smooth show over there. So I think we took a bit of a tricky situation, and the staff were so great, we kind of turned it around. So those patients on the old palliative care unit ended up being transitioned to the unit that Morgan is running right now in order to make a COVID specific unit for patients that contracted COVID while in hospital. And so I've been reassigned to that unit to look after patients specifically with COVID-19. So that's kind of what I'm doing now.
Okay, thank you for your work. I did want to ask, how do you find communicating with folks who might have dementia when there are face masks and shields, et cetera? Have you found different ways to communicate with them? What does that look like?
Yeah. That is definitely a challenge because many of them are hearing impaired, and you know, we as human beings rely so much on nonverbal communication techniques. So I would try things like to keep my name tag with my picture on it of me smiling, and I kind of show it to them so they could say, you know, typically I'm someone who likes to smile. I don't always look so serious with this mask on. I don't know. And I think as Morgan was saying, Kim's going to talk a lot about the virtual connecting with people. So we relied on that a lot. But yeah, it is tricky to kind of communicate people with a mask on, for sure.
Thank you.
Yeah.
I know. I personally find it hard to know like who's actually talking to me, because you can't see their lips moving, and I have a hard time knowing if people are talking to me or to somebody else, because it's really hard to, especially when you don't recognize their voice. Do you have something you want to add, Deb?
Yeah,
Deb's our speech language pathologist.
Hi, I'm Debbie. I'm a speech pathologist. I think it's really difficult because obviously you can't get the facial expressions, and and looking at somebody's mouth, knowing who's talking to you. Interestingly, I've been, looking at articles from the States and stuff, and there have been some people, speech paths in the States, who are finding this exact problem, and they, especially with the deaf community, actually, not talking about dementia, but the deaf community, because they're lip readers, and they started making masks that were, sort of the visor was at the mouth. so that you can actually see through it, which I thought was a really cool idea, but I have not actually seen them here. So that would be interesting. The other thing I've seen, and maybe others have seen the posts, where people have been printing out their picture and their name and they're pasting it to their gowns or whatever, so that you could actually see who it is behind the mask and the gown. Because when we're on droplet precautions, we've got the visor, we've got the mask, and we've got a gown on, so you cannot see our tags anymore. So that's problematic as well. So that's kind of a neat idea. I also saw that some people are printing a t-shirt with their picture on it, so that they just wear that t-shirt every day, so at least you know who the heck it is behind this mask. And I thought that's a really cool idea too. But for the dementia clientele, especially the geriatric clientele, the hearing issue is huge. We do also make sure they're wearing their hearing aids if they have any. And we do have these audio ports that we lend to people if their hearing aids are missing, or if we notice they have a hearing problem and they have no hearing aids, or they're too expensive or whatever. So we have been handing those out on the unit as well.
Sorry if I can jump in just for a moment. I know I'm not in Parkwood, Maine, but I'm in Parkwood Mental Health, Terence, and I work a lot with people with dementia. And as mentioned, it's a lot of nonverbals, and we use body language a lot. So always identifying yourself, tilting your head, using your tone of voice. If appropriate, with your 2 meters, you can take your mask down for a very difficult situation, just to allow them to know who it is that's approaching. But the tone of voice, the body language, the actual acknowledging who you are, and who's speaking is really important for them.
You know, it will be really important to capture some of these aspects.
Yeah,
some of them will help. Some of them will help in the go forward, regardless of the mask. Especially the issue. Also, this is an area, Terence, that also is close to my heart clinically. The tone of voice is critical. The tone of voice and the posture of the body. People know if you are standing or if you are, speaking a bit like this, like still, because some of these issues you will experience even without the mask. The tone of voice and the posture especially. So there are silver linings of what we can learn for good times.
We've actually learned that the mask has not interfered as much as we thought it would. So that's amazing. Sorry to interrupt.
Thank you, and thank you, Allison. It's been really great to get to work with different people from across different programs during this whole pandemic. So Kim Denai is a therapeutic recreation specialist who has been working on 5B South, who normally works, I think, in day hospital, Kim. And Kim's going to talk to us a little bit about the virtual connection work that we've been doing to help our patients stay connected with their families.
Hi, everyone. Thank you for giving me this opportunity. I just want to start out by saying I really feel that being put on the virtual team is a real gift. The joy and satisfaction that I see from both the patients and families honestly warms my heart. Every single connection that I'm helping these patients have. So I did start out on the SAMU1 unit with Allison and that team, and when those patients were transferred over to 5B South, it only made sense that I already had a very close connection to those 11 patients, that I would follow them over to 5B South and continue to work with those patients and the families. So since then, of course, the unit has expanded to 40. So myself and another colleague have divided the 40 patients. And so we're each we're working with the families and patients. So with the virtual connections, we're using a variety of different platforms, and solely it's based on the preference of the family. The biggest issue, or it's not really an issue, but the hardest work there is just really getting the families set up. A lot of families, surprisingly, are not comfortable with virtual connections initially. So just a lot of educating first with the family and figuring out what platform would be most successful. So truly the common denominators on the 5B South unit that we've been using is Zoom in order to do multiple visits with multiple family members like we're doing right now. Facebook Messenger, which typically isn't supported by the hospital, but in this circumstance, we've been given privileges to be able to create a false account to allow those families that opportunity without having to introduce yet another variable. We're using Skype and then FaceTime. So truly we, on 5B South anyways, we're trying to offer as much virtual connection as the family wishes. So truly the team that I have been assigned to, these families are incredibly dedicated and devoted to wanting to speak with their loved ones. So I would say a minimum of 3 to 4 visits a week, and then as well trying to accommodate visits in the evenings and on weekends. This particular team has been working evenings and weekends as well to accommodate the requests of the families. Evenings haven't been overly popular at this point because most of the family members are home. But as you know, we start to transition back to more and more people working, I think we'll see the need to implement more time on the evenings and weekends. I'll have to say that there's been so many success stories, and I could take up a full hour of sharing all of those with you, but I do want to share with you that I worked very closely with a patient who we recently lost 2 days ago, and 2 of her children lived in London and her other 3 lived afar, Vancouver, North Bay, and Halifax, I believe. This patient was 99 and was going through different periods with her health, and you know, some days she was quite responsive and alert to their communication, and other days you could tell she was listening, and I think that was really helpful for the family on the other end, especially when the patient didn't qualify at first for visitors to be coming in to see her. So we did a variety of different things. We would set her up for Zoom for weekly family calls. In addition, twice a day, I would link with at least 2 of the children individually so they could have some of their own private time. We were using headphones in order for them to specifically have private time with their mom. And at the request of family, I would sit at her bedside and communicate back to them when their mom would respond, because her voice was so soft. And you know, as much as we can see each other now, they couldn't always see the expressions on their mom's face. So it was really important to them for me to share with them, your mom is laughing softly right now. Your mom is opening her eyes to whatever poem you're sharing or story you're sharing. So that is just one incredible gift that I was able to do with a patient and their family. In addition to the virtual visits, what's started to happen now is to be able to do some window visits downstairs. So we're actually bringing the iPads downstairs as a method to communicate, to be able to hear each other, but then the family is on the other side of the window, and you know, it's a pretty powerful thing to see the patients reach out and families touching each other just even through the window pane. So incredibly successful, and certainly I think the families are pretty happy with what's happening. Now, we've talked about the complications with dementia, so certainly some of our patients are confused at first with regards to seeing their family member on the other side. So just a lot of cueing is used to help them recognize that we are looking at a picture, but it's important to continue to listen to the voice. And certainly things would be stopped if in fact the patient was agitated, but at this point we haven't been told that it hasn't been beneficial from the nursing staff for the patients. Did you want me to talk quickly about the TR space, or just leave it at virtual connections?
Like 1 minute.
Yeah, okay. I know I'm a talker. So as well,
good talker.
Background role is therapeutic recreation. And of course, these these patients love to be engaged from social leisure. We all know that that's a good thing for our quality of life. So Morgan has allowed us to take a room and turn it into an area that we can offer individualized leisure. So truly, if a patient is interested in more active outdoor things that they would do, bocce, you know, putting greens, those kinds of things, we have that opportunity. We have an indoor curling set we're using. And then to the other extreme, we have lots of passive leisure opportunities. We're doing journal writing, crafts, individual arts, just reading with people, reminiscing, etc. So I think from a staff perspective, the nurses are sharing with us that all of those interactions are definitely helping improve some of the loneliness and behaviors that we were seeing with patients early on. They are settling in quite nicely.
Thanks, Kim. It definitely has been really great work to have the TR support on the unit to help the patients be engaged and motivated. It really has been helpful to have an interdisciplinary team on the unit. So next we're going to hear from Eliana Caranci. So Eliana is she's saying right beside me, but on a different computer, not right beside me, an appropriate distance away from me. But this is on a different computer.
Hi there. Again, my name is Eliana. I'm one of the occupational therapists on the unit. There's 2 of us for the 40 patients that we are serving. And there are 2 physios. So I'm representing both the physiotherapy and the occupational therapy programs on the unit. And I'm hearing some feedback.
I think if everybody puts the computers on mute, it will work well for you. Or you may have your cell phone close to your computer. Move that one too.
Physio assistant during the day. And on the evenings, from Monday to Friday, we have a physio and an occupational therapy assistant to assist as well. So, you know, first when this program quite opened, it was very different. All of us coming from different areas, coming to group together. I was the first OT up here and just helping out the nursing, collecting all their equipment, making sure that things are in place for commodes and bedside, mattresses and anything that they needed, alarm bells. So things were a bit challenging at first, but I do say we have come together and things are coming together quite nicely. So we are serving, as you know, the population waiting to get into long-term care. And it has been a challenge because it came from acute care, really unable to do a lot because of the COVID situation. And I think because of the staffing has been variable. Of course, we all know acute care is quite busy. They've come to a rehab program where we have rehab hats. So we have found that we are getting people more mobile. They're up, going, walking more. They're turning more in beds. We're getting them into a physio and occupational therapy space where they're doing some exercises. So almost everybody on the unit is on a program where they're either being seen by the physiotherapist once or twice a day, as well as occupational therapy at least once a day. And when I say twice, that's with the assistant as well in the evening that's giving us a hand. So we are noticing things like they are more verbal, they're certainly up walking more, they're able to toilet more at the toilet, so they're doing a lot more functionally. One of the challenges that we have found is that trying to get equipment with vendors being restricted from coming into the hospital was quite a challenge, as well as the fact that they're in a holding pattern in terms of where they would get their equipment needs. So these individuals have come in without wheelchairs or walkers and needing them. So we connected with another occupational therapist that is off the unit that quite assisted us quite a bit. And we did obtain at least, I would say about 25 wheelchairs from community donors that we were able to bring in, clean, make sure that they were safe, explain to the family members that this is something of a donation. So we really did give it to those individuals and those families that are struggling financially, and knowing as well as when they go out in the community, there may not be a therapist to finish their ADP applications. because of the fact of the COVID situation and the lack of therapists that are going into nursing homes right now. So we are getting them up every day, which is really neat, and helping like the families and the patients, making sure that they're able to attend to their rec therapy programs and be able to interact with the family as much as they can as well. So we're doing quite a bit now that is more functional than at the beginning, where we felt like we were putting out fires, but things are a lot now.
Are you doing more now than what you were doing pre-COVID?
Sorry, Doris, I can't hear you. Because you have to unmute your volume. Oh, sorry.
Yeah, I'm unmute. Sorry. Are you doing now more than what you were doing pre-COVID with patients, with people, with clients?
Sorry, Doris, I didn't hear you because our volume wasn't on. Can you repeat that?
No worries. Are you doing now? Can you hear me?
Yes, I can.
Yeah, good. Are you doing now more than what you were doing with clients pre-COVID?
I would say, because my job was different, I can't really comment, but I can tell you, and I think we have Southwest Lynn here from the hospitals where they came from, and I think they would agree they are doing more.
So again, I think similar to what Janet and our colleague from speech language pathology said, there are a lot of silver linings that we need to take notes. And also for our colleagues that were talking, I don't see her that she was talking about the one that said talker, Kim, capture those stories, because I think some of these are silver linings to take forward, like in our private lives, right? To take forward some of these learnings and some of what we are doing now can serve our clients and their families much better in the go forward.
I agree. I also think it's a lot easier that we are, from a therapist that has had 20 years of inpatient experience, I am focusing on one population on one unit has made quite a bit of difference. And they see a familiar face and they understand what the routine is going to be from one day to another. So that's been, I don't know if that is going to be the norm, unfortunately.
But well, those are things I think we need to think. And this is also for Terrence and for us from a policy perspective. You know, this issue, for example, of personal support workers working in 3 places, got to stop, not just for COVID, got to stop, period. People need to work full-time or whatever they want to work in one place so the patients, the clients, the residents, their families know them. Like some of these things are the issues we need to push, go forward for the benefit of people that use the system. And the same goes for therapists. So leave it with us.
Okay, great.
It's that whole continuity of caregiver that you're talking about.
Critical.
That is so important for everyone, all of the team.
One thing that I've kind of just listening to your story there and I've wondered about it before. I believe when a patient is deemed ALC in acute care, they no longer get funding for even small amounts of therapy. And those, as you've mentioned, they're bringing them over to a rehab setting and giving them not really active rehab, but just gentle support and mobilizing has enhanced the quality of life that those individuals are having. So instead of being completely dependent on on others for care and needing full support, they've made small gains to be in an assist ×1 to get from bed to chair, which in itself increases a person's sense of independence and mobility
and value, self-identity.
Value for self, yes. So I know, Terrence, just one of those things that we struggle with in transferring patients to long-term care is that if they are making small gains with tiny bits of physiotherapy, that once they get to a long-term care facility, there's it's a physio, I think once a month that comes. It's our CCA or our Lynn partner there might be able to further clarify that, but just those tiny interventions are huge for personal self-satisfaction.
I'm going to plug in my OT though too, because occupational therapy is all about maintaining independence. And we have found that we are allowing them to do more things for themselves, which in turn makes them less behavioral as well. We're not pulling on them, tugging on them, telling them this way, telling them to, you know, how to pull their pants up and down. We're giving them the time to figure it out on themselves and demonstrating and showing it. And the nursing staff, with the extra nursing staff that we've had on the unit in the last couple of weeks, maybe a week now, has really helped as well, because they're just following all the concepts that we are teaching and doing. They're now having the time to do it with their patients too. So it is staffing is a huge issue.
It's staffing, and it's the way we see the world and we behave towards clients. I mean, I would suggest an organizations that have done it, that use the person-centered care, BPG of RNAO, will start to do all the things you're saying, right? Because we relate to people as people and not as doing to them. So I don't want to steal from Morgan more time, but I think it's a lot of learnings that we need to take forward.
Just from the Lynn perspective, it does go a ripple effect, because as the more independent patients get, the less behaviors they have with the,
exactly.
The more long-term care homes find these patients, like they will accept these patients into their facility because their care needs are less than what they were and less behavioral. So really there's been
I don't know if I wouldn't call them more behavioral, that already tags them, right? This is reactions of people to their circumstances. And the more we relate to people as people in whichever space they are, the less people will react. So do we, any of us.
Absolutely.
Not only related to a dementia. So, you know, sometimes, again, it's the learnings for the future, right?
Absolutely. We're seeing that improvement in patients, which is what we want, and for their well-being at the end of where they end up for their home for long-term. Yeah.
Sorry.
No, I was just going to say there was a huge bulk of patients that came from UH and LHSC on restraints. And, you know, we only have one person right now who we're trying to wean off. And that is a huge number. And I think that's what you meant by behaviors. It's just the responsive behaviors.
It's the response of people.
Yeah.
If you
it's not the intent to label.
Go to any of our nursing homes that are BPSOs for Terrence, best practice spotlight organizations, which Parkwood is, by the way, that they use our guidelines, Morgan Unities. You will see they don't have side rails, period, end of story, no restraints. It's all the way we relate to people as people.
Right.
It's
actually, it's a perfect marriage that St. Joseph's Healthcare, speaking with RNAO, because it's caring for the whole person and considering them like the human being that they are, and how many different dimensions they have, whether it's mind, body, spirit. But also, you know, speaking for myself, I can say that if I were restrained all day, probably the first thing that I would do would be to lash out after I was finally taken out of restraints.
Absolutely.
Conversation I had with Janet some time ago, I believe it was a couple of years ago, was about the Butterfly Project and the importance of treating people like human beings and the person-centered care that should be in long-term care. And it's so critically important. So I won't take any more time.
With respect to the Butterfly program, which I love, $250,000 a year for a nursing home, take the BPG, the best practice guidelines of RNAO, free of charge. We will train you free of charge. Canada made, free of charge. Ontario made, put it to use. And many organizations are doing it without paying a cent and having the extra support of RNAO. So,
thank you, Eliana. And so now Amber Woods is a registered nurse that works in our infection prevention and control department, who's going to talk a little bit about her role as an RN there, and then also talk a bit about what she's been doing during COVID.
Thank you, Morgan. Yep, my name is Amber Woods, and I'm one of the infection control practitioners here at Parkwood, and we just have a really small team of just 4 ICPs, and it actually was a team of just 3 in December, but fortunately we had one of our retired ICPs come back to us to step up back up to the plate and to help us navigate through these really challenging times. So that was really awesome, and we have two really extraordinary leaders, our coordinator, Redora, our director, Wendy Reed, and a very kind and patient medical director, Dr. Michael Silverman, that we go to for his expertise and knowledge to help us through some of these situations that we've never dealt with before. And then we have an awesome occupational health and safety team that we've been working really closely with, more so than I have in my 5 years that I've been here. So that's been great for us to be able to rely on one another, help one another, especially when we have those long days, when we have some unfortunate situations. So our team, really what we do is we're providing that subject matter expertise and guidance to our senior team, our clinical support service staff or physicians in matters related to COVID-19. Our team ensures that all practices and our procedures related to COVID-19 are in line with that evidence-based information. And every new development of information are something that we critically evaluate to ensure that we provide the most appropriate and responsible evidence-based recommendation for our staff and for our patient population. So with these unprecedented times, this pandemic has changed our lives as individuals and as a team. Things continue to evolve and change, and what we know today might change tomorrow. So it has certainly been challenging, a challenging time for everyone, for our team, with increased demand of IPAC expertise and support, which has made it really difficult at times to balance work and family life. I have a husband at home who's trying to work from home, but we also have 3 children, so two, 5, and 8. So just him trying to balance all those multiple different roles. I pray for him every day. But this is what we're trained for, and we see this as an opportunity to share our knowledge and our skills. And we're part of a village of St. Joe's, and everyone in the village plays a really vital role. The global shortage of PPE has added a new layer of focus and concern. So whereas before we usually have an abundance of supplies of PPE, but now we must focus on conversations, responsible stewardship of PPE. So we have to reevaluate our infection control measures and our guidelines in order to meet the shortage of PPE supplies. Infection control's role is to evaluate the appropriate PPE and the development recommendations that will safely extend the life of PPE. So there is growing evidence regarding various methods of extending the use of certain PPE and related or limited reuse, cleaning, disinfection, and reprocessing of certain PPE, including face shields, N95 masks, and surgical masks. Our team is continually assessing the changing environment to ensure the safety of our staff, physicians, patients, and residents. And I'm proud of our team and our staff for stepping up in which is a challenging time for everyone. I'm honored to be a part of such a caring, dedicated, and committed team of healthcare professionals.
Thank you, Amber.
Thanks, Amber. There's no doubt that infection prevention and control has played a huge spotlight in helping to keep our patients, residents, and staff members safe. And the dedication that you guys have to making sure everybody stays safe has really been evident throughout the pandemic. It's been really great to work with such a collaborative team and who's always willing to answer questions and provide additional information or clarity to both the clinical and the support services who might have different understandings of what it is that we are doing with PPE and particularly around PPE conservation. So thank you for all of the work that you've been doing during this. Henry is next. So Henry Vandepoel is an RN who's working here on 5B South. And Henry comes to us from the Neurobehavioral Rehab Center, the NRC, which is a program here at Parkwood. So he's going to talk a bit about his role usually and what he's been doing during the pandemic.
So in essence, the Neurobehavioral Rehabilitation Center works with brain injured patients that are undesirable behaviors. We work with them so that we can make them potentially go back home to the community again, or back to a nursing home if that is an area that is fit for them. It's a highly specialized unit. Anyways, the role that I have there is there's only one nurse that works there at a time, and typically I'm in charge, and there's 4 rehab therapists on days and afternoons, and we work one-to-one with each patient. We work on the behavior mod with them so that they're, we try to make them better, right? So as best we can. We use different approaches. I have a big bag of tricks that I use to make, to help them be compliant with whatever the needs are with them. Like, I'll use an example. If we'll go up to them and we give them choices, right? Like, do you want to brush your hair now, or do you want to brush your teeth? And then it just kind of gives them the control back so that they're more compliant with what has to happen. Anyways, I got redeployed to this 5B South, which has been awesome. Like, it's the whole team, we all came together. Staff morale is really good. I've been able to help teach people, staff here, about different techniques and approaches to different patients that know how to work with them, right? So that they're able to be more, pardon the wording, compliant and able to do more things for themselves. I've been able to be a resource here, and yeah, it's been fun, right? So we've been getting a lot of new grads coming in, and we're able to teach them, which is, it's just fantastic. So I'm really glad to be part of the team out here, and yeah, we're doing great. So.
Yeah, we have a really great and diverse team of staff members here on 5B South, and it's been really great to get to work with people and put people in roles that are different than where they would normally be worked, so they can really develop kind of a whole host of skills, and everybody comes with a specific expertise, and understanding the knowledge and experience that every staff member has been really helpful in making the unit be as successful as it has been. So Henry's doing great. We're really happy to have him, and to have all of the other nurses, PSWs, rehab therapists, allied health team that's come from different areas who all have different background clinical expertise. Amanda Thibault is here with us today. So she is our Director of Professional Practice. So Amanda, do you want to talk a little bit about professional practice and their role?
Yeah, sure. I'm happy to do that. And I'll keep an eye onto the time because I see we're getting close. So I have a team of 6 practice consultants that really support the whole organization. So as Roy mentioned, we've been focused more on 5B South at Parkwood Bain, and we support organizationally. And so we help make sure that the practice guidelines that Amber's team kind of works on are disseminated and being rolled out equally across the organization. And that all of the elements of a professional practice environment are present and I would say implemented across all of our sites. So things like, are we making the most of everyone's role and helping everyone truly focus on what they need to be doing? So I think some of our examples that we've heard today from SLP really helping with communication and being able to make those recommendations back to the team, the real importance of having OTs and PTs along with their assistant roles so that we can really have focus the OT and PT role on doing the assessments and then utilize the assistants to help do the more day-to-day activity so that we're able to run as efficiently as we can across the organization and make sure that patients while they're with us are really getting the best care that they can and maximizing all of their, I would say, potential to kind of live their life fully once they go on to their next place after they leave here. We have really needed to shift, I would say, to be responsive to what the needs are during the pandemic. So my team has, we shifted at first early on in really helping HR and on behalf of the clinical leaders do all of our interviewing and rapidly bringing on new nursing staff. So we brought in an additional, I think, 60 new staff early on within the first 6 weeks of the pandemic. So we were doing full days, interviewing 10 people a day, and had 2 full-time team members doing that. We also then were supporting clinical teams that started to do some of the remote virtual care across the organization and making sure that they have good documentation practices, that there's, kind of some of the maybe not so fun aspects of healthcare in terms of documentation standards, and we're, meeting all of our legislation requirements, some of those kinds of things, but just setting, I would say, staff and patients up for success by having some structure and support available there. And then doing a lot of consultation and planning for worst case scenarios. So, you know, we're lucky in Ontario that we are not seeing that acute care surge response. But if we did see that, really making sure that we had resources in place to think about how we might deliver care differently. What would care look like if we needed to, you know, if we lost a third of our workforce, what would that look like? How might we need to deliver care differently? And being ready for supporting the teams and making those transitions. The other, I would say, big focus, to Amber's point, she really highlighted well the focus on PPE. And so we have been helping make some of those connections between the supply chain and clinical leaders and logistics around what PPE do we have available, and using that information on the clinical side then to say, and the operational side to say that, you know, you might want to do a whole bunch of things, but this is what we have to work with. And so that's a very different manner in which we've been needing to think about the care and services that we deliver, and thinking about it not only organizationally, but from a regional perspective. And so really helping to, with the expertise from IPAC, how do we help ensure that we are conserving our PPE, we're only using it appropriately, helping with education around PPE so that individuals know how to do conservation safely so that they're protecting themselves and the patients as well. And having everyone kind of working hard together on being aligned with those conservation techniques as well.
Thanks, Amanda. It really does take a whole village to make it a successful experience for our patients. And I'm so thankful that we have such a great group of people at St. Joseph's to work with and to support. Thank you everybody for attending. If we only have another couple minutes left, is there anybody who has any kind of burning questions? Or Terence, is there anything that you want to add or to say, or any questions that you have?
Well, you know, I'd just like to say, hearkening back to Doris's words, it is very much our hope that we will take from COVID-19 and the difficulties it has brought our community, that there will be silver linings. And I think you folks have really shone a light on so many important, thoughtful things, that it does take a village, that when people come together and are able to excel in their different field, and when everyone is working together, you are taking care of the whole person. The considerations that you have made, whether it's communication or taking into account someone's independent needs, it is so incredibly thoughtful. I cannot thank you enough. This has been truly eye-opening and beautiful for me. You gave me chills. I kind of wanted to cry at times. You're lucky I didn't. But
no, nothing wrong with that, Terence.
But I can't thank you enough, and I'm so looking forward to investigating more of the BPSO. But you folks, you are the embodiment of thoughtful care. And I mean, without you, we would be in a very different place with COVID-19. So my heart goes out to you. I thank you for everything you do day in and day out.
So I just want to say thank you to you, Terence, for attending, and to you, Morgan, for organizing and asking all your colleagues who we know are very busy to share with us. I leave you with one request, which I mentioned before, and now that I have everybody there, they cannot say no, anybody, including Morgan, to write a 700 word, we can even send you this tape on really this amazing work with some of the silver linings, because I think we need to capture as soon as possible some of those silver linings. The communication through the eyes and through the whichever, the shirt, you know what I mean? Some of the really pearls that you shared with us, and probably the overlaying pearl is the immense capacity to work as a team. It's just beautiful, right? And you know, we get back to the norm and everybody's in their thing and everybody's rushing on their thing, and then we forget all of this. So if you can, as a team, under Morgan's leadership, because I had asked her and she probably started something, but now based on this richness that you shared and also with Terence's questions and comments, I think it brings the community, and they call it village, call it whichever we call it, is just amazing. So happy People's Week from the nurses to all of you. Thank you.
Yes.
Thank you.
Anybody else have anything they want to say?
Angela, maybe? Angela?
I just want to say that I commend the multidisciplinary team for the collaboration and putting the patient first and meeting the needs of the patient. And your collaboration has to do a lot of the willingness of the staff and also the leadership at your organization. So I wish you a great success in the future. And for those of you who are nurses, happy Nurses Week. And I celebrate with joy. And on behalf of RNU, we commend you for who you are: competent, compassionate, caring, diligent healthcare providers. And for what you do, you provide care, you put self aside, sometimes even at the neglect of your families. You do that just to provide care for patients. So congratulations on who you are, what you've done, and will continue to do. God bless you. Have a wonderful week. Bye.
Thank you, Angela.
To all of you, thank you. Really, big thanks. And thanks, Terence, for joining again.
Thank you. And thank you to Morgan for organizing. This has been a wonderful experience. We need more nurses, and we need to roll out this model of care across the province.
And our professional practice. And our allied health teams. Thank you.
Okay. Yeah, I must be.
Leave meeting.